You pick the guy that looks you in the eye,
Yep.
that tells you what he's going to do,
Yep.
and you pick the guy that's not a jerk.
Okay, thank you for saying that because yes, we need to have somebody who's competent and skilled. However, the honesty, the integrity, the looking at you in the eye, and not being a jerk were some of the reasons why we chose the surgeon that we did. Get the surgical notes because the patient is not going to be told the information. They're just going to be told it was a success, we cleaned it up, everything went great. And when you're creating a customized program, we want to be as detailed as possible. When you can read a surgeon's dictation notes and how they go step by step and how they find things and how they fix things and how they find things, that helps you create your plan for post-op. You can see the names of the structures that you need to hit.
Anybody that has been that abused as a child, you have to run 40 and 89 until the hippocampus just stops perceiving everything as a threat.
One of the things that we try to teach is to think your way through the situation, is how did we get here? That's the new slide that keeps repeating in the FSM rehab course is how did we get here? Because it's not just pathology and it's not just tissue.
And it's certainly not the diagnosis they walk in the door with.
Thank you for subscribing to the Frequency-Specific Microcurrent Podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at Frequency. Find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn McMakin.
Oh, you got the black memo.
I get that memo quite a bit, actually, so.
Nobody would believe that we don't plan this.
We don't.
Yeah. How are you doing?
I'm great.
Better?
And Kevin's in black too. He just showed his appearance that he also got the memo.
Yeah, it's good.
I'm great. I missed you last week. I appreciate the grace in not appearing when we literally just got out of the surgical center.
Yeah, no.
So my brain was in
How's her leg?
shoulder.
Shoulder. Oh, that was a shoulder?
Dislocated shoulder. She had a tear in the labrum from 12 to 5:30.
Oh, that's bad.
A completely destroyed bursa, a Hill-Sachs, a Bankart.
How did she do all of this?
Hockey game.
Yeah, but getting slammed into the boards or?
Yes.
Yes, that's like hitting a brick wall at 30 miles an hour.
Yeah, this was her second dislocation, so I have a lot of shoulder stuff to redo for the FSM rehab course. The shoulder dislocation post-operative section just grew exponentially.
Yeah.
And I have so much to share about post-operative procedures because and I sent you pictures of such great healing.
No bruising.
No bruising.
Has the surgeon seen it yet?
No, I told her when she goes tomorrow to make sure she sends those. She's getting the stitches out, so he'll see. But I wanted him to see how great it looked after 2 days.
Yeah.
Getting them off of painkillers right away. There's so many things that we know what we do with FSM, but until we're in it in real time, we tend to forget.
How unusual it is.
Exactly.
Yeah.
There was a woman that was talking to me about her son who had a similar procedure, who after 3 weeks is still on prescription painkillers, is still sleeping in a recliner because he can't sleep in a bed because of the pain, who can't go back to school. My daughter was in class 48 hours later.
Yeah.
Because she's my kid and she's a nerd and she loves what she's learning, and Mom, I'm fine, just take me to school. But there's the pain, the bruising, or lack thereof is something that, like I said, we know it happens, but when you see it in real time, this doesn't get old.
No.
And it's only you that I could share it with, and you're just like, yay.
Yay.
Because you expect that, but anybody else was like, when was this? I'm like, 2 days ago. That looks like it happened weeks ago. I'm like, exactly.
Months. Yeah, no, you get used to doing the impossible on a pretty regular basis. After you're finished, I have to tell you what happened this week with the midbrain.
Okay, I want to hear that. I need to debrief two things.
Download.
One
Go.
one thing for the practitioners that are listening that I think is an invaluable tool that we typically have access to is get the surgical notes, because the patient is not going to be told the information. They're just going to be told it was a success, we cleaned it up, everything went great. And when you're creating a customized program, we want to be as detailed as possible. So I did get the call from the surgeon. He knows what I do. He gave me a very detailed procedural accomplishment that he did. However, when I still asked for the notes, because he forgot that he plucked out the subacromial bursa because it was trashed. I would like to know that there was frond-like synovitis. We have a frequency for synovial tissue, which I will talk about after because I know it's investigational, but I have an idea.
Oh, it works.
It works.
Not investigational anymore.
Good. So when you can read a surgeon's dictation notes and how they go step by step and how they find things and how they fix things and how they find things, that helps you create your plan for post-op. You can see the names of the structures that you need to hit. It's not just labrum. Yes, the labral repair was a huge component of it, but when you think of a Hill-Sachs or when you think of a Bankart, this is now getting
What's
into
a Hill-Sachs? Remind
Hill-Sachs is the deformation that happens on the humeral head, and then the bank is the deformation that happens on the fossa. So you can have when the shoulder comes out of the socket, it clinks and you can have a significant dent in the humeral head, and that can catch on the labrum. So he had filled that in so that it wouldn't catch anymore. And they do that with the supraspinatus, piece of supraspinatus tendon.
Oh, that's too bad.
Well, it's just a little piece.
Just a little piece.
Nothing crazy. So the periosteum, the bone now becomes the 157, the articular surface. These are all things that should start appearing in your brain as you're writing the post-op protocol. And there's a great post-op template in our mode bank that it's not like you have to write it from scratch, but your post-op day one, open it up, go in and just see, do these structures, are they relevant in this case? Do I need to add structures? What happened to the structures?
When they take out the bursa, what do they expect to do the job that the bursa did? The whole glidey thing.
The whole glide, that was my question, but the bursa, it's like having diseased tonsils. If your bursa was not doing its job and it was
Sticky instead of glidey.
exactly. So the saving grace with my daughter's shoulder in this case is that she had immaculate, strong, juicy rotator cuff muscles and no tears whatsoever. So when we think of the structure of the ball and socket,
That's miraculous that you can do an anterior dislocation with all that damage and the rotator cuff just takes the joke.
and she dislocated twice. So she did once 3 years ago and then again just this December. But this was my point when we're talking about shoulder dislocation and shoulder rehab. I don't know who designed the shoulder, but there's many flaws, right? We use the golf ball and the tee analogy, and then we turn it sideways. So having a strong rotator cuff was what kept her healthy and kept her playing. And that's what's going to make her rehab very enjoyable for her because that's what keeps that shoulder together. Yes, the labrum helps, but when you think of the depth of the labrum and the humeral head, it doesn't provide that much joint strength, right? It's the strength of the rotator cuff.
Yeah. That's when my shoulder was all broken into six pieces. When he got the pieces together, vacuumed up the fragments, and put the humeral head back in the socket, the greater tuberosity was sheared off. As soon as he got the humeral head back in, the rotator cuff pulled the whole joint together, and all he had to do was pull the plate because the rotator cuff was in good shape.
Yeah, we love it when the rotator cuff is happy and healthy. And this child of mine, when she went off to college, she says, I don't care that I don't have a car, but can you give me a custom care to take? Of course. And I do really think her connective tissue is so healthy because of FSM. I 100% give that credit. So sometimes it's about the immediate post-operative result, and sometimes it's looking back and saying, I wonder what situation we would have been in if she hadn't been treating herself for 5 years, almost every day.
It's like you run shoulder, there's a protocol for shoulder pain, but you can turn it into shoulder support by running inflammation and torn and broken, because we get micro tears in the flat tendons all the time.
All the time.
Just
And
reaching up into the cupboard and grabbing that thing that you thought was light turns out to be heavy.
the micro tearing is such a huge component of the DOMS protocol, delayed onset muscle soreness, what we put on for athletes to recover after a game or after a workout or after a run. Micro tearing is part of movement life. And I really do credit 49 and 81 vitality and increase in the secretions to the fascia, to the connective tissue, to the synovial tissue, to all those places that need that lubrication. So because she doesn't have a subacromial bursa, will she need to do extra things? Maybe. Will she be pain-free? Because that's not doing its job anyways. A little bit of reorganizing, but she's doing great.
Oh, that's so cool. Yeah,
Yeah.
I had my mom fingers crossed
I
for
know,
you
I
because
appreciate, and
it's
there were
like,
so many practitioners that had heard the story that were sending good vibes and emails. So I appreciate all the good thoughts from start to finish. One other thing too, I'll talk about going through this journey and talking to different surgeons. There is something very real about getting a good feeling from somebody and getting a bad feeling from somebody. And I was trying to tell my daughter this, and she didn't want to get a second or a third opinion. She said, "Mom, I don't want to be rude." I'm like, "Well, it's not about being rude.
oh,
Surgeons should be used to sharing their opinions and the collaboration. And when 4 out of 4 pretty much said the exact same procedure needs to be done, I said, this is great. Nobody's scared of anything. Nobody wants to do anything extra,
or
but
different.
or different, and it's a good feeling to know everybody's on the same page.
There is a point where FSM practitioners are patient advocates and patient educators. And I tell patients, let's say, that need a hip replacement, assuming their insurance is okay with it, I said, you interview 3 different surgeons in 3 different separate practices,
Yeah.
and you pick the guy that looks you in the eye,
Yep.
that tells you what he's going to do,
Yep.
and you pick the guy that's not a jerk.
Okay, thank you for saying that because yes, we need to have somebody who's competent and skilled. However, the honesty, the integrity, the looking at you in the eye, and not being a jerk were some of the reasons why we chose the surgeon that we did. And he was very competent, and this was a quote unquote textbook labral repair. So it's not like there was a technique that only one surgeon does and whatever. I like the fact the surgeon talked to me like a medical professional, but he also talked to me like a mom and
Mhm.
said, I have a kid and I can understand you're in California and she's in New York, and I'm going to fill you in, and this is what we're going to do. And I couldn't imagine if my daughter had to go through surgery. And there is
Oh,
something very human about that experience. And sometimes surgeons can be not like that.
well,
And
there's something about a surgical residency that I believe removes part of their soul. I don't know if it's deliberate or coincidental, but the
well,
poor things.
we can ask Dr. Reynolds that. And when he comes to lecture on PRP and stem cells for us in Arizona, one of the reasons why I built that relationship with him is because he is one of those people you just described. A really good person will look you in the eye, can explain things to you that's not condescending, and that isn't over your head. And there's a balance between that as well. You need to be informed with that's not, it's more than just informed consent. You need to be informed of all the options that you have.
And they have to be willing to put in writing that you can use FSM immediately after the surgery when they're in PACU if you have to.
Right.
And it's okay. The ones that aren't threatened, the ones that, and the reason I said we are patient educators and advocates is patients need to be told that they have this option. They're not being rude. They are customers, and the
Right.
surgeon works for you. And
Right.
the look on their face when I say that is, oh, yeah. I said, you're about to pay this guy $7,000. It's like buying a big piece of jewelry or a used car. It's a thing.
Yeah. Yeah, the options that are available to patients in the PACU, right? That is also something that you can discuss with your surgeon before you're in that PACU. So we talked about FSM. I talked about how I don't like ice. I don't feel that it helps. We have so much research now that it doesn't help with healing. It impedes circulation, right? It's an analgesic. If you're waking up from surgery, hopefully you've got pain meds still.
Well, I got invented morphine.
And something that's really interesting, and this might be something to talk to, I I want to float this in Arizona quite a bit. Our regional nerve blocks, and maybe Heather, our anesthesiologist, might be somebody to talk to. But my daughter is 0 for 2 for having a nerve block work. Both times they had trouble doing the nerve block because of her fascia. And both times she woke up with full sensation, motor and sensory.
Well,
So I shouldn't say she had no motor control before surgery, which was great. But when she woke up, she was in full pain.
yikes. I was very grateful for mine. They
Yeah.
inserted it and it had a little bulb that slowly emptied itself over 24 hours.
Okay.
And after 6 fractures and a dislocation and all that stuff, the but they couldn't get the needle in.
When she had her ACL, no, it kept bending and moving around in her groin, and they had a lot of trouble.
Whoa.
Yeah. And
Hmm.
yeah, and they blamed it on fascia.
It's easier than blaming it on the resident that was trying to do it. So that's another conversation. Not
Yeah.
all
Yeah.
are created
No.
equal.
But yeah, to your point, you want to, going back to that post-surgical procedure, have the conversation of, I have a device, it's called FSM. I'd love to have it on me the minute I wake up, or have somebody apply it if the person doesn't want to put it on without your family member or whatever. I can understand that component.
People need to know that PACU is post-anesthesia care.
Right.
So those are the nice nurses that, number one, keep you from barfing,
Yeah.
deal with you if you are barfing, watch your vitals as you're coming out of anesthesia because some anesthetics, general anesthetics, create cardiac anomalies, create dysrhythmias, do all sorts of crazy stuff because everybody metabolizes anesthesia differently.
Yeah.
And so you go right from the OR to post anesthesia care, and you are in PACU any place from 30 minutes to 2 hours, depending on how your body metabolizes anesthesia. So when I woke up after my neck surgery, I had George and the PACU nurse applying sticky pads under the bandage that was post and anterior. And that's where I found out when you have an anterior disc, the thing that is painful is not the soft tissue, it's the facets.
Mm.
Because now your neck has a curve for the first time in, I don't know, 15 years.
Right.
And so so that's just an aside, but back
Yeah.
to you.
No, these are all things, like I said, that when we go through either ourselves or a loved one, we just see them with just a different lens.
Yeah.
And the post-operative care that we received was very open-minded. I can't say enough good things about from the start to the finish. So an incredible team all around.
Yeah.
And starting PT, starting movement. I think it's so important to rename protocols in their custom care that are positive. We credit this all the time with Roger Billica talking about the nocebo effect, not just the placebo effect, so staying positive. So we talked about torn and broken, maybe we rephrase that to repair and heal, saying things like I get to move it. You get to move it at PT. You get to take the sling off and you get to move things. Not you
Mhm.
have to. These are all really important. And when things do get sore after PT, you have a tool that's going to help you because yes, it's going to be sore.
And there's no thing to call it except for delayed onset muscle soreness.
But to phrase it as a very positive, to be expected feeling, so that panic, because
Yes.
especially athletes who have had repairs, there's a lot of panic. They probably were playing in pain. And for us, a big part of it was get your shoulder's not going to hurt anymore. As after today, it gets better and better because the
Act-
repair is done. Healing
Actually,
starts.
it's the phrase might even be better. Your shoulder's going to be a lot more comfortable now.
Yes,
The
exactly.
H word, probably not, if you can avoid it.
Yeah.
Sometimes you have to use the P word or the H word, but it might be more comfortable than it was before now that it has been repaired.
Right.
That's
They're all
good.
really positive words. And we talk about when patients are on your table, especially when they're prone, they're in that hypnotic state to avoid using phrases. And I think, that is true. Even we learned this even before FSM, but it's especially true when FSM is running. They're incredibly more, especially if you have those patients that do get really floaty. Be very careful with your words. Keep it
Actually,
happy.
believe it or not, I have a section about that in the advanced.
Yes,
I
good.
have 100 I just got the count from Danielle, 141 in person, and this is still a month and a half
To go.
before,
Oh,
and 74 live stream.
amazing.
So there's a section on hypnosis, there's a section on acupuncture meridians in the hip, the shoulder, the spine,
Yeah.
big section on the dura, big section on the spinal fluid and where it goes and what it does. And then, yeah, and then I'll tell you about the midbrain in a second.
Yeah, I think I'm done debriefing. I appreciate there is just so many, like I said, little pieces aside from the structural and the pathology that is going into writing her protocols. Can we attend any of the live courses via Zoom? Yes, you can attend the advanced via live stream.
Oh, yeah, it's all live stream. The nice thing about David Eakes is he's been filming me for 17 years now.
Wow.
It's crazy. He started in, huh?
Something like that.
Something like, yeah, forever. So he mixes on the fly. So he switches from slides to my face to the crowd. We have a second camera crew that we hire locally that does what we call B-roll. So we'll take different views, and David just keeps it mixed up. So when you do live stream, you get it all because of how good David Eakes is. And
He
it's
knows you and your movements and he knows the course and what needs to be shown. It's like a well-oiled machine how everything flows.
Yeah, he's just so good. So there's a page in Netter that shows the bottom of the brain and the cranial nerves that come off the medulla, and then everything from cranial eight, no, eight, nine to cranial two come off of the pons.
Right.
And the patient presented with trigeminal neuralgia. And then she wanted to zoom through her history. And you know how I am. It's, wait, no, go back. Then what happened? She's almost my age. She's 77. And she talked about her first husband 15 or 18 years ago killed himself, and she's the one that found him. And she said it was like a claw went into my heart because there he was. And it's okay. And then fast forward X number of years, they found out she has atrial fib, and they've got her on Eliquis now. And she said, I have this pain right side of my head, have this pain here, and then it goes here and here, and my face muscles are really tight. And then every now and then I get these little wavy things in my visual field. Really? And then my face muscles are real tight. And then I have, but her presenting diagnosis, what she was sent for, was trigeminal neuralgia, level 7 pain in all 3 branches of the trigeminal nerve. And then, oh yeah, and by the way, every now and then on my right side, the sounds get really loud and bothersome. She just described every cranial nerve from 8 to 2. The wavy things in her visual field, the eye, right? Optic nerve. Then the eye muscles, she said, and sometimes it's just really hard. It's like my right eye just goes cattywampus. And then the muscles are really tight. That's the facial nerve, because that's motor. Trigeminal nerve is sensory. And then there it is, 8th nerve, cochlea. Everything from there to there. And I said, so when did all this sort of start? Oh, long time ago. And if you thought I thought my way through it, it's like, you've been having TIAs. You've had atrial fib for, I don't know, 17 years. And you're not having a stroke, you're having little microclots. And I found out about microclots because that's what George had, because he wouldn't take Eliquis and he had atrial fib. So little microclots. And they go in, they don't block the artery to that part of the Pons. They just make it ischemic for a little while. And then part of the tissue just doesn't work very well for about an hour or 2. And then all of a sudden it's fine. And then this part, and her face state was tight. The right side, she said, the right side of my face is paralyzed. She could move it, so it wasn't paralyzed. But if you felt it, it was tight. So it's denervated, denervation hyperesthesia. It's tight. Trigeminal neuralgia. It's worse at night. Yeah. So I said, can't hurt, might help. She's Buddhist. She meditates. She's done all of the internal work. So she's done all of the hard stuff.
Right.
All I had to do was fix her brain. So I did. I know.
You need to, okay. Yeah.
So I just picked, and her other complaint, and that she'd never told anybody. The other complaint was just a really strong startle response. And then somebody someplace told her that because her condyle had been broken off when she was about 8, because her mother was physically and emotionally abusive, broke the kid's jaw when she was 8, knocking her across the room, hitting her on the side of the head. And it's okay. And that practitioner told her that all of this trigeminal nerve stuff was because of this fracture she'd had when she was 8. She's 77, and none of this started until about 12 years ago.
Right.
So I did 40 and 89 from neck to abdomen for 60 minutes, quiet down this, and then treated the Pons for the basics. And I just had my hand on her arm, and I did the basics, got to 40 like that, because ischemia causes inflammation. And so I ran inflammation, and then I wanted to run increased secretions, because that's how we were going to get all these cranial nerves to work again. And her arm just firmed up. And it's okay, too soon. I get it. We just have to give the Pons a little love. So we went from 40 to 49, and we ran 49 for 20 minutes. Then I could go back and run 81 and touch her face, and the muscles softened up. And how's your trigeminal nerve feel? She said, doesn't hurt. So you just get the Pons to work again. Any wavy things? No. How's this sound? Fine. Doesn't bother me. Okay. And I think so that's what we did on day 1. Day 2, she said, I don't know if it's related. I'm thinking to myself, of course it's related. She said, I had this terrible headache that started here, and she traced the ophthalmic branch of 5 and the back. And I said, oh, you just have adhesions in the dura. Excuse me, how do you figure that? If you're throwing microclots, you're going to have inflammation. Inflammation leads to adhesions, and the dura goes just, if you look at where the medulla and the pons are on the bottom of the brain, there's a section of the dura that's under there. So it makes sense that the dura would be stuck to the ophthalmic branch of 5.
Yeah.
So I said, can't hurt, might help. So we did cranial work, and you could tell that her mom was left-handed, because the whole right side of her skull, for those of you that do cranial work, the sutures are supposed to meet here. The right side was like this. So we just ran scarring in the dura and had her hold her breath and do a Valsalva and then move things. And then, so after the cranial work, I had one machine running on just 40 and 89 the whole time, ran concussion in Vegas the whole time. And then when I came under her jaw on the right side, this, where the Vegas comes out, was stiff. So the jaw fractures bleed. So we ran scarring in the Vegas, and that's when she floated off. And then it was time, and I ran the emotional frequencies. So you start with anger, because there's part of her, I don't know I don't care how much Zen you do, anger is buried in the hippocampus. Then resentment, then fear or terror, because you're 8 and your mom's knocking you across the room. Then fear and over concern, and then grief for the 2 husbands that had died, and then restoring joy. At the end of it, the right side of her face was actually puffier and more mobile than her left. Pain was a 0, and she was absolutely giddy. It was so much fun.
Oh, I have so much to ask you about with this story.
I wish I had the page open on Netter so you could see all the cranial nerves on that page. It's on a slide in the advanced.
And I don't think I have it here. It's in the clinic.
Yeah.
But, okay. My brain just is.
Sorry.
No, I'll go from the most recent thing and then I'll work my way backwards. So one of the things that we try to teach is to think your way through the situation is how I like how did we get here? That's the new slide that keeps repeating in the FSM rehab course is how did we get here? Because it's not just pathology and it's not just tissue.
And it's certainly not the diagnosis they walk in the door with.
Right. So, yes, it can be helpful to have these structures, but you have to use your own hypothesis and you have to listen to the story to get to that. How did we get here? And how inflammation isn't just inflammation. What happens before that inflammatory process? What happens after inflammation? And I think that if I look at the mode bank and I look at my old slides and my old case studies where I spent a lot of time using 40, I thought 40 was really gonna help me. And I think it did help me. But where I really started getting results and closing the door on cases was when you think about how did the inflammation, why did the tissue get inflamed? And if something is chronically inflamed, what happens to that tissue because of that inflammation? So that was one thing I got out of your story. The next is a question, and I know we have questions to get to. But when you're going through the emotional sequence that you walked through, you've got such a great background that can help you think about the layers of emotion. I would have agreed, I would have got to all those emotions that you talked about based on the clinical history, but how much is it relevant or important to layer it in that way? Do you think if you went from restore joy first and then anger and then grief, do you think like the sequence is okay?
Yeah.
Because there's been so many times where I'm like the emotional frequencies didn't work, and it was because I didn't put it's the same thing like I said. How did we get here? It's not just about being afraid. There is anger and there was resentment and then there was grief. So,
And there was 2 hours of 40 and 89. So emotions come from the amygdala and the hippocampus.
right.
And so as long as her startle response was she said her startle response scared people that were near her. So somebody would slam a door, she would jump, and the three people around her would go, "What?"
Yes.
So we'd run 40 and 89 the day before. She wasn't ready for 970s.
And so that let's unpack that too. Running the emotional component. I know people just want to get there and they're just like, "Oh, she's terrified." But there is so much that needs to be done. Again, it's thinking your way through it. You just don't get scared. So there's treating 40 and 89 first.
Yeah. And
Sequence.
then we talk about this in the core, but it's at the very end when everybody wants to catch their plane and they're brain dead anyway. But the one frequency, emotional frequency that you can get in trouble with running is the one for grief. So we had the woman who had lost a child 3 months before the class. Her two boys had a genetic condition. She took the older of the two to the emergency room. The doctors wouldn't listen to her and said, "Go shoo, mom." And he was dead by morning. And so she told the story of my son had just died. And during the practicum, back then, the classes were mostly women. And so there's four women gathered around this woman, and she's just weeping buckets. And I went over and looked at the machine, and they were running 970 and 17. And I just, without telling them what I was doing, I ran 970 and 35. She wasn't just grieving the loss of her son. Her presenting emotion, as far as I was concerned, was rage. She was furious with the doctors. So I ran, once I switched to anger, the waterworks stopped. She stopped crying. And then I ran resentment, and she started breathing more normally. Then I ran fear because she has a younger son, 3 years younger with the same genetic condition. And then I ran over concern because she's really worried about him. Once I got through those 4, then I switched. And this is all, they don't know what I'm doing. I've got the machine turned, I'm just pushing buttons. Then I ran 970 and 17 and she was fine. Then I could run, right? 970 and 17 is grief because the emotion associated with the lung is grief. Those of you that aren't acupuncturists, 35 is the liver, which is anger. 38 is the gallbladder, which is resentment, or resentment's close enough. Then 27 is the colon, and that's terror. 23 is the kidney, which is a more yin kind of fear. It's worry over concern. Then the lung is grief. And then 970 and 33 I met up, and that seems to be restoring joy. So we could run them in that order, and she was fine. So grief is the one if you run that first. So this woman had 3 years before lost her second husband, who had died of whatever, Alzheimer's, I think. Her first husband committed suicide. So that was part of our conversation. It would have been really easy to jump to grief, but I just knew better. And anybody that has been that abused as a child, you have to run 40 and 89 until the hippocampus just stops perceiving everything as a threat.
Right.
And once the hippocampus and the amygdala, because we have one frequency for the whole midbrain,
Right.
and that's the amygdala, the hippocampus, and the thalamus. And I don't, George has frequencies for the amygdala, the hippocampus, and the thalamus, and I haven't found any one of the 3 of them to work. So I'm sticking with 89.
Yeah.
And once we did that in that order, 2 days in a row, and I said, tonight you get to get used to who you are now. I'll see you Thursday. She's just, I don't know who I am. You'll figure it out. And she was hilarious. It was so much fun.
If we're not you, and we're not, how do we break down those emotional components? Do you have anybody like we could read?
I just read because I break it down in the core and then again in the advanced. It really is a predictable sequence.
Right.
Why are you angry? Fear is always behind anger. That's a psychology thing, but it's right.
Yeah. That is like psychology 101. Think about road rage, right? You're driving in traffic and someone cuts you off and you get angry and you scream and you shout and you honk your horn. Yes, you're angry, but right before that, you thought you were going to get into an accident and you were scared.
Yeah.
Right? So
you can run fear first,
yeah,
terror first, and then anger. Just depends.
Right.
You're not going to get I've never gotten in trouble by getting those 2 wrong. The only one I've ever seen people get in trouble with was the one for grief. And that's a surprise.
Yeah. Yeah.
And then anxiety and depression, those 3 sections, 3 slides in the core are really important. If the patient is depressed, if that's their primary complaint, and their vitamin D level is 12, they're not depressed.
Right.
Until their vitamin D level is 30.
Right.
And they haven't done the vitamin D, but they live in Minnesota and they don't take vitamin D supplements and they have depression. Let's So let's get somebody, if it's not part of my scope, let's get somebody to order a vitamin D level. Why? What's that got to do with it? Then you explain.
Right.
I'm on these antidepressants. You just stay right on them and we're going to get your vitamin D levels and then we get your vitamin D up. Once your vitamin D is between 30 and 60, then we can start seeing if it's possible to wean you off of the antidepressants. And that is my personal prejudice about Effexor and Celexa. It takes a year to get off of those two.
Wow.
Prozac was easy by comparison,
Right.
and amitriptyline is really easy. It's a thing. And some of this, I guess I have to tell them the truth. Some of this you learn by making mistakes. It's just part of the learning process. You learn more from your mistakes than you do from your successes. Remember the guy with the big toe, the pain in his big toe?
Yes.
Okay, and I figured I was two different nerve roots.
Yeah.
He came back and he said, I run inflammate that nerve, so it's 40 and 396 and 81 and 396, and then scarring in the nerve. I run that and that helps, but the pain is still a 7 at night. It's denervated. Ugh. So I ran 40 and 89 for phantom limb pain, and his pain went from a 5 or a 6 down to a 0. I said, you have phantom limb pain in your toe. All right. So we ran that, but then he said, yes, but running 40 and 80, 40 and 396 still helps. And it's, what if you didn't completely tear it? What if it just got seriously tractioned? So one of the days I worked on him, I ran neck to feet, neck to toe, 40 and 89, but then from his knee to his toe, I ran three machines. Inflammation in the nerve, because the nerve isn't going to work as long as it's inflamed. Increased secretions in the nerve. Come on, sucker, move. And then torn and broken in the nerve. If you remember that picture that goes with nerve traction injuries where it shows different stages, what if it's stayed not completely torn, but just shredded? Okay. And I just left that run while I worked on another thing that he had in the back of his leg.
Right.
And he got off the table and went, oh, that's different.
Wow.
He could put a sock on. The thing in the back of his leg happened at the same time that he was doing all the stretching and the muscle cramping and the tightness and the spasticity. He said, there's this knot back there. It just feels tight. And I did connective tissue and I did deep hole bruise and I did all this stuff. And then I opened Netter. What is my hand on? There's nothing there, even in the cross section. Blood vessels, fascial compartments, none of it worked. Peroneus brevis? No. Okay. So I ran torn and broken in the muscle belly. Never used that before. And that's all your fault. 46 actually works. Okay. Deep hole bruise in the muscle belly. And the knot that was like the size of a kidney bean just disappeared. But then the sore place, the hard place moved. And what is that? Open Netter. Oh, you idiot. It's the fibula. It's what the muscle attaches to. Right? Remember that diagram in Netter where there's the little red thing where that's the attachment of that muscle? So I treated inflammation, scarring, and torn and broken. And yeah, that was about it. And the periosteum, and it was done.
Yeah. That I understand.
Yeah, that was like, oh.
Yeah. And again, you're thinking what your way through. Sometimes opening Netter gives you that visual of what tissue is here. And it's not just going through the anatomy of the peroneals. What do they look like? What's their shape? How do they attach? What's the tendon look like?
And what do they do?
What did they do? If they were stuck, what would that feel like? What would that look like? Let's try. and then
And if he tore them and they bled, what would it look like? What would it feel like?
And again, that's going back to how it's not just an adhesion, right? Yes, adhesions are there, and it would be great if we could treat everything with 13. But things just
No.
don't get scarred or adhered for no apparent reason. Was there an injury? Like you said, did something bleed? Was something bled onto? And then what happened? Is that where the adhesion happened? Because then it's not just running 13, it's following that story back to how did we get here?
Yeah. And what's sore? It's so cool.
Yeah.
We do have a lot of questions.
Yes, and we're running out of time. Okay. EDS client removed scarring and greatly improved range of motion in hip. We did a short repattern before she left because she came to the sports rehab class. Great.
Yay.
Then the next day she was dizzy and nauseous. From other training, this would indicate too great a change in proprioceptive recalibration. Ran some more pattern change in Vegas. She was better second day post. Aside from new patterning programming helping, does this also sound like detox? If it is proprioceptive, aside from new pattern, what other things? Okay, I'll let you go because
It's driving me crazy.
Yes.
So I just had this conversation today because I have to do this lecture. There's Daniels or hypermobility patients. They are much more prone to vestibular injuries. So Suzanne, did you happen to do vestibular screen on her?
That
So
was the first thing that jumped out. The nauseousness doesn't typically happen because of proprioceptive feedback.
no, she's got a vestibular injury. So do a
VIBS.
vestibular screen and a BIVSS, and I bet you're going to find it. It's really interesting. I'm supposed to do this several lectures this year on Ehlers-Danlos and or hypermobility HEDS. We don't get the really severe ones. I don't even touch those. I don't even see them. But we get the HEDS, and their logo is a zebra because they're supposed to be unusual. In every single class, 20%, if not 30% of every FSM class is hypermobile. Patient population, it's 20 to 30% of the people we see are hypermobile. It's the first thing I have them do, mostly because it's one of the easiest things we fix, which is also a very weird thing to say. So yeah, that's the problem, I'm gonna guess.
Yeah.
Home at 124 and 77, 40 and 10, 91 and 27, 91, 217. 217 is not a tissue. 214 is the labrum, but I'm 91 and 217 tends to be the mineral that's involved in older patients and athletes in general. 46 is muscular tissue as a tissue type. And for 30 some odd years now, I've been saying I didn't think it worked. 46 is muscle tissue as a tissue type. 47 is the digestive system. 48 is something, 49 is something, 50 is something that just didn't make any sense to me. And then you showed that 46 does seem to be for the muscles. So that's still the only one I believe. And then because I didn't think 46 worked, 62 is arteries, 162 is capillaries, and 62 I said was muscle belly because the muscle is so well vascularized and it has elastic tissue, which arteries also have.
Right.
But they're different. I lied.
Yeah.
Yeah, for a really long time, I lied.
You just didn't know. I don't know if it was lying. It was just,
Well, I know.
and it was there is some voice that just would not shut up about 46. And so there's a big component in the sports advanced class. The slide is called sarco something because I do think part of it is the muscle proper, like the actual filament,
Sarcomeres.
myofibril component. It
Yeah.
could also be the sarcolemma or the sarcoplasm because that is also reactive.
Yeah.
That's a whole other talk. But
Okay. Back to Suzanne. Can you explain more about removing scarring relating to vestibular injuries? Okay. When you worked on her hip, you changed her whole gait.
Right.
And when you change the bottom, if you look at how she holds her head, everything is connected to everything. And as she walks, she's now just built differently. And her vestibular system, I'm going to guess, can't accommodate. So 40 and 44 is what we use to relax the neck muscles, stop the dizziness. It's temporary. It only works while you're running it. 44 is the inner ear. Yeah. And so try that. And it's when I work on somebody's hip, pelvis, complex, leg, feet, whatever, and there's a big change in their gait, I have them walk, you run 81 and 84 from their neck to their feet while they're on their table, and you make them do resisted toe movements, but that's not weight bearing.
Right.
So you get them up and they walk to drum major, toe first, then heel, toe, heel, and they are wobbly and discombobulated for 50 or 100 feet. Our corridor is 25 feet long. The first two times they walk it, I grab the back of their pants, so I serve as a gait belt, and it's okay, I'm not going to let you fall. And they go, I have no idea where I am in space. It's okay. Look, go ahead, look down at your feet. And then once they've done 50 feet, I said, now try and look ahead and feel the bottom of your feet. Pay attention to your feet on the floor. And they are walking barefooted or in socks. And then at about 75 or 100 feet, they start smoothing out. And when their shoulders relax and their arms start to move, then you can let go of their belt and you just keep them walking toe heel until it's smooth. You can watch it happen.
Right.
Okay, now you can walk normally and look
Right.
straight ahead. And then it's in a corridor, so they can reach out and touch the walls if they have to for balance. And it takes that long. It's usually a good 15 minutes for the inner ear and the brain and the cerebellum to figure out where everything is in space and how everything's moving. Don't feel bad, Suzanne. It's just, no, you didn't get anything wrong in terms of what was repatterning. It's just, it surprised you. I don't spend time on this. Kim probably does, but neither one of us spends enough time. And you only find this out by doing it and by having it go sideways the way you did with that patient. And Ehlers-Danlos patients are more likely to have vestibular injuries, so they don't have their inner ear to help their cerebellum.
And just to add something too that we do go over a lot in the sports, and it's that whole afraid to move. Somebody who has Ehlers-Danlos, who's hypermobile, and you've created a big change, you need to scale that proprioceptive. I don't know what you did with the repatterning, but sometimes just standing, eyes open and eyes closed, is what you need to do for patterning. If they don't feel safe in a movement pattern, then you have to feel safe standing. So again, you have to go back. But people, the nausea and dizziness is not to do with repatterning. That doesn't happen. That's when patterning is all about getting muscles to fire that have been offline. This is a whole other sort of piece.
The other thing that you can do before they start walking, depending on how much you've rearranged the furniture in their body, is you stand with your feet hip straight and then step forward and step back, step forward, step back. So all they're doing is practicing the movements that will be associated with walking. Step forward, step back, step forward. And they are surprised at how wobbly they are.
Right.
And so you have them do that until they can do that without being afraid of falling over. And then you grab their belt and you head out into the hallway and you do the next thing. And I don't know where to put that in the core until we make the core 6 days, and nobody's ready to do that. So we're late, but can I do a quick drive-by?
Yes, let's finish off Julian's question really quick.
6 months ago, I rushed down a hill during a hike. Down a hill. Next day, my Achilles tendon hurt. Yeah, it's not about the Achilles. 124 and 191 for a couple of weeks. Oops. Still hurt every time I get up to walk. Down a hill. That's okay. There's connective tissue, 77 next to. You can also try 195, inflammation in the tendon sheath, and then torn and broken, good plan, in the periosteum. And all I can think of right now is the muscle. The Achilles is what hurts, Julian? Kim, what do you think?
Yeah, going down through me, I would have thought the Achilles would have been more strained on an upward part of the hike, but what goes down probably went up. So maybe it was actually under strain if he went up first and then went down. So again, trying to figure out what happened. But there's a lot of
downhill, you land on the heel and the Achilles is going to get stretched.
Yeah.
But it shouldn't take a couple of weeks to fix an Achilles tendon strain.
No, I don't see fascia anywhere, and the fascial component in the posterior leg is huge.
Yeah.
So that would definitely be something I would 124 for sure. Vitality, increased secretions, get all those structures. The other thing, the impact on the heel, we have a major fat pad underneath. So I'm thinking of like the plantar fasciitis type of protocol where I spend a lot of time on the fat pad, 397. Right. Just because it's been a while too, I think maybe you could try that.
And he says the heel bone hurts. So I'm with you on the bone bruise part, Julian.
Yeah.
That's a good guess. So I'd go with bone bruise, especially if you're going downhill, you're going to slam your heels. And yeah.
The calf pain, sometimes foot pain, it just takes a bit, unfortunately. So I would just make sure that the plantar fascia, and the fat pad structures in and around the foot and the longitudinal arch are happy as well.
And the other thing you might think about is if you look at the referred pain pattern for trigger points in the gastroc and soleus, they refer pain to the heel.
Correct, yeah.
And the Achilles. So it could be just referred pain from trigger points in the gastroc, soleus, and that other one that's gastroc, soleus. What's the one that runs?
The peroneals.
Yeah, that. So Netter, back at Netter. It's a good question. That's a good conundrum.
Let us know next week, Jillian.
There we go. Okay, we did it.
We did it. We debriefed. We got all caught up. Thanks everybody for coming.
It's fun. And I'll see you next week.
We'll be here. Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this